All righty.
Y'all need to chime in. I'm sitting in the back.
Don't leave Pam hanging. There we go. Well, we're glad you're here. We've got a few empty seats, but maybe some other people will trickle in as we get started, but we're glad you're here. And my name is Mike Wade. I work for New River Valley Community Services.
Holly Lesko, New River Valley Regional Commission.
So we are here today to talk a little bit about the Opioid Abatement Authority project, the Recovery Ecosystem project that was recently funded. We'll get into that in just a few minutes. And we're also going to talk about 4 categories related to this topic that we want you to chime in on. We'll have lunch here soon, pizza from Domino's. Woo, woo. So we'll have that soon, but that'll be on the house. We're covering the tab for lunch, but you have to talk today. That's part of the deal. That's how you get your free lunch. We have to have input from you, especially since we only have a few people here today. We really want to hear from you. We want this to be engaging. We want it to be a conversation. So we want you to give us ideas, thoughts, concerns under 4 key areas: prevention and education, harm reduction, treatment, and recovery. Okay? But before we get into that, we are going to go around the room and do quick introductions. So if you would indulge us, please give us your name and tell us who you work for. Sarah, we'll start with you.
And the
Yes,
mics here.
microphones, because we are live streaming. Thank you, Holly, for reminding me. You have microphones near you, in front of you on your tables. So the folks at home who are watching can hear you clearly. Please speak into the microphone if you have a comment, question, or you're introducing yourself. Now, Sarah, it's all yours.
I am Sarah Frazier with Carilion Clinic.
Chris Alderman, New River Health District.
Beverly Hill, New River Health District.
Erica Short, New River Health District.
Robin Blackwell, Lewis Gale Pulaski, Behavioral Health Unit.
Yeah.
Vicki Collins, Radford City Department of Social Services.
Dee Frith, NRVCS Community Wellness and Outreach.
Grace Bocchino, New River Community College.
Amelia Bertner, Community Resilience Coordinator at United Way, Southwest Virginia.
Pam Ray, New River Health District.
Dylan Lohr, Women's Resource Center.
Mads Waddell, Women's Resource Center.
Patty McComas Hall, Women's Resource Center.
Great. Thank you all again for being here today. And Holly, I'll turn it over to you.
Sure. You should have a sheet in front of you that talks a little bit about what we're calling the New River Valley Recovery Ecosystem. It's a proposal that was submitted to the Opioid Abatement Authority. We pulled this together in May. It's a cooperative application. The state of Virginia is settling their opioid funding at a statewide level. So localities, counties, and cities receive direct allocation from those settlements. And then the state took a chunk of that money that they are allocating through competitive sources, as well as if localities are willing or committed to spending 100% of their funding on opioid abatement and opioid prevention work, they get an extra 15% of the opioid funding. So those are ways that the state is trying to encourage. Some of you my age or around my age or a little older will remember Tobacco Commission money, that there was some concerns that funding didn't go directly towards treatment and recovery and prevention. And so this opioid funding is really being designed so that it will predominantly go towards treatment, recovery, prevention, and other activities that are directly related to opioid use and misuse. So when we came together as New River Valley, this region, where I feel really lucky to be in, is a very collaborative group. The local governments all understand that we're much stronger as a group than we are individually. So Montgomery County, Floyd County, Giles County, Pulaski County, and the city of Radford agreed to submit this proposal for competitive funding that was available through the state and to put forward all of their direct allocation funding towards this collaborative work. This work is happening across the region. There's, as you can see on the list, everything from working in the schools to expanding beds at New Life, to taking a look at studying things like supportive housing. How do we do a better job with on-demand transportation? And then also taking a look at adolescent inpatient care. We don't really have anything local in that realm right now, and do we need it? Do we want it? We want to do some studying so that we can do things, not, a lot of things we're ready to do that are what you can kind of call shovel-ready kind of activity that we know we've already been doing and we just want to do more of. But then there's some things we want to take a look at, like what are things that we might do differently, better, or in a more expanded way. And so between study and activity money, there's $3.4 million that we intend to spend in this first year. That funding has not officially been released yet. It technically started July 1. So we're still in some negotiation. Montgomery County agreed to be the fiscal agent on this project, and each one of our localities will sign memorandums of understanding with the county committing their matching funding to the activities in the area. Everything from recovery court to medically assisted treatment, something that is unique to our area that I think was excited the grantors was the mobile unit that we have in this area. During COVID, there was a bus purchase for the health district to use, and that has 2 exam rooms on it. We weren't able to utilize it as effectively as we'd hoped during COVID due to all kinds of logistical hoops and administrative things that had to be jumped through. Those have been settled. Now the intention is to combine services that could be from any one of the partners, New River Valley Community Services, Community Health Center, Health District, and others, to provide services across the region that can be both for prevention and treatment with opioid abatement. So with that, I really just, if there's specific questions about the proposal, I'm happy to answer it, but also we're still in the phase of gathering information. Even though this funding has been allocated into these buckets for our region, there are some specifics that are yet to be determined and decided. So this is an opportunity for you all to say, in Radford, we want to make sure you don't forget X, Y, and Z, and in the region, these are some things that I'm seeing that we might want to consider. This is also 5 years of money. So in this year 1, we're going to be starting things. We also want to be flexible. If things aren't working, we're not going to keep doing those things. We can redirect funding, and they have been very flexible with us at the state level to do that. So that, I think we could jump in and learn more from you.
All right, great. Julie, if you wouldn't mind, just grab a microphone and introduce yourself since you were a little late getting in. Oh yeah, let's do that. You get one all to yourself.
Yeah.
My name is Julie.
It's on.
It's on.
My name is Julie Fox, and I am the NRV Resiliency Network Coordinator.
Thanks for being here. All right. So lunch will be here around 11:30 before we jump into that. With what Holly's just shared around the project in general terms, are there any specifics, anything that comes to mind, any questions that you have that we can try to address before we jump into the heart of the discussion? Or anything that's maybe on your radar that we haven't thought about yet?
Or those of you who've heard me before, what did I forget?
Leadership team meeting next Wednesday.
Yes, on the 30th.
On the
So we're gathering information to share with them. That will include all of the localities as well as the organizations that are going to be doing the bulk of this heavy lift. But yeah, still really trying to understand how we can best do this work in a way that is impactful in each one of our communities.
Who really is on the leadership team?
Each of the localities has an assigned person. And so Radford, Pulaski, then usually it's the county administrator, but in some cases, or the city manager, if they are unable, they can have a second person who can stand in for them. And same thing for the organizations. New River Valley Community Services, New River Health District, New River Valley Agency on Aging, Community Health Center of the New River Valley, a lot of New River Valley names in there, aren't they? And then New River Community Action and New River Valley Regional Commission.
I'm just thinking it's really important for localities to know who their point person is so that they could send information directly or have a direct conversation, especially if they haven't been able to sit in on these meetings. So can you publish that list somewhere with emails or phone numbers?
Sure. I think we're trying to let this meeting we're having on the 30th will be when the leadership group will come together and have some conversations exactly about those things, like who's the person to contact when you have something, maybe for sure, if you have something concerning your locality specifically, you should contact your city manager or county administrator. Or I don't think there's any reason not to share that information, but I also think the intention is to form technical teams around some of the topical areas. For instance, we already have a communications team that's starting to look at the campaign. We certainly will have somebody else coming in? Yeah. Oh, Domino's. Okay. Okay.
Emil's not Domino's.
Yeah, no, he's not. Emil's not Domino's. He went the wrong way. There he is. Okay. Thanks, Emil. So, yeah, I think that there are going to be lots of opportunities for people to be engaged. We also are working on a landing page for this work so that as things change and evolve and people have an interest in being supportive and or have questions or concerns, there will be a particular person who can answer that question. In the same way that we're trying to address treatment to prevention, like there should be no wrong door for how to access this. So if you call somebody from the city of Radford, they should at least know where to refer you if you have an interest in a particular activity that's going on. But still, as Pam was saying, I said, we're still building the plane. She goes, oh, you're still creating the materials for building the plane. We're trying to think outside the box without doing things inappropriately. So.
I do think your city manager / county administrator would be a good point of contact if you have anything specific that you want to share about the locality here in Radford or wherever. Okay. Before we jump into the conversation, since lunch is here, we're going to break for that in just a moment. But I quickly wanted to make a plug for the two events that you see promoted in front of you. These will both be happening next Thursday, which is International Overdose Awareness Day. But before we get to that, Emil, you just joined us. If you wouldn't mind just take a microphone to introduce yourself.
Hi.
It's for the live stream.
Oh, over here. All right. Hi, I'm Emil. I'm with the Women's Resource Center of the New River Valley. I'm a community outreach specialist there.
Keep it at your spot there. So the clergy summit that starts off the day next Thursday, International Overdose Awareness Day, that'll be at Belmont Christian Church. That's for any clergy member, faith-based leader, all denominations, all religions. This is a very inclusive, open event. We would love to have folks there from all 5 jurisdictions, ideally. That's free. And then the event with Sam Quiones, author of Dreamland and The Least of Us, will be at the Inn at Virginia Tech at 1 o'clock that afternoon. He'll be interviewed by Tom Landon with Blue Ridge PBS, who is actually Beth Macy's husband. Fun fact.
Fun fact.
And then that evening, you don't have a flyer in front of you, but we'll gather in front of the 401 Peer Center here in Radford that night at 7:30 for the annual candlelight vigil for Overdose Awareness Day. So even if you can't attend, help us spread the word. We'd love to have these events at capacity and fill all the seats.
And if you haven't heard Beth Macy speak yet and you still want to, tomorrow night she'll be at the Moss Arts Center at 7 o'clock and it's free. So it's part of the Rural Education Summit, but it's all free.
That's right. So, yeah. You can't say you're bored. We've got plenty for you to do.
That's right.
All right. Dee, are we all set back there?
Yeah, we have cheese, pepperoni, and
Supreme. Yep. All right. So why don't we go ahead and grab lunch, and then when we come back, we'll start the conversation. Sound good? All right. education, harm reduction, treatment, and recovery. So we'll just start at prevention and education since that seems to make sense. So in thinking about prevention education as it relates to overdose, opioid misuse, addiction and substance use disorders in general, would love to get your thoughts on what we're doing well, what we need more of, what we're not doing currently, what we need to do a better job at, what are we missing, what should we do more of. And wide open. Just remember to pick up your microphone nearby if you have a comment or a question.
So one thing that I've noticed in our work is that opioid addiction is right there with domestic violence, which means either the kids we investigate have to go live with different family members or they come into foster care. And I was reading about something from another state, can't remember now which one it was, but they kind of expanded the use of peer recovery, where not only did they have people that were recovering from addiction, but also maybe people that interacted with DSS and were successful at getting their children back and pairing, almost a specialized peer recovery specialist and matching those people up with people that are involved with our system.
Do you have can you email that to me, Vicki? Because I do think we don't need to reinvent the wheel,
Right.
but it'd be nice to know where people are successful. And we also know that sometimes it's policies and regulations we need to work on. So if there are things that we can manage locally to make sure things are functioning better, we really want to do that too.
Yeah, I just think it's a real opportunity because the peer recovery program, I think, has been really successful.
Absolutely. Yeah. I love that. Bev?
So on the public health side, I know that with regard to the Department of Health, our focus largely is harm reduction. And that being in mind, I think it's really important to have good data in terms of knowing how to focus our efforts. That's one area that I see a lot of challenge right now, but I'm hoping will evolve over time and that we can really get more voices involved in that development of a good standardized or more standardized way to achieve that. Does that make sense?
Do you have particular data that you want pursued or things that you think would be really useful?
Well, right now I know that OD map is being developed and that several of us from the department have now received training on it and we have access to it, but it's not necessarily reliable. So just any way to focus our efforts on local populations so that we can then tailor our response. And I don't know what's in the works, but I do know there's some talk across VDH, and there are conversations started about bringing people at the state level down to the local level into that conversation. So any knowledge that anybody in this room or across the district has on good data sources or ones that are begun but could be further developed, I would just be very interested in knowing more about those.
There's a lot of delay with data related to drug use, overdose, ER visits, that kind of thing. Which, if you think about it, and this has come up, I think, in another one of our sessions that we did, more real-time data like what we had with COVID, you know? It seems like that should be attainable.
One, how to share it.
Yeah.
I mean, that's also one of the things we've talked a lot about is like between, again, some regulatory things that keep people's individual data safe. We definitely want to do that. And how do we not let that be a barrier to sharing information that would be useful across, like I had a meeting with supportive housing folks who said we really need to know medical data so people who are coming out of any kind of treatment and want to get into a housing situation, we need to understand what their needs might be so that those wraparound services can be real and sincere. And yet, how much of that individual's health data is appropriate to share and with who? So
It does seem like the data, it should be possible to have it more real time because, when they started Medicaid expansion, because I had to deliver those numbers to my board, there was a map and those numbers changed.
Yeah.
When I clicked, it's hard to click on Radford because it was tiny.
It really is.
That's right.
I would try to get Radford and, but we were able to get really quick data, not 2 or 3 years ago, as
Yeah.
to how we were doing in terms of enrollment.
Yeah.
So I feel like the technology is there, the apparatus is there, but it's just not real time across the board.
And whose job is it to manage it? Sorry. Yeah.
Yeah.
So I can only speak anecdotally because this is not data that we collect, but I can tell you that the Women's Resource Center sees the correlation between domestic violence and sexual violence and substance abuse. I mean, in many of the systems that we work with, like for example, when we go and work with the forensic nurses doing emergency advocacy, there's a number of the people that we see that are not only there because of DV and SV, but they also have substance abuse issues as well. And whether it's because that was part of the hook, to get them to stay in a relationship is to get them addicted, or whether they're using it as a coping mechanism, it is there and it exists. But we also see it a lot in our shelter. When somebody's coming into our shelter, it's often very hard to help them deal with the DV issues that they're experiencing, when the substance abuse might be the actual primary concern. And the barriers that exist for them being able to get help and treatment for that are really hard. We don't have the capacity to drive people to Pulaski every morning, to go to the Suboxone Clinic, or, to get them to all the different places that they need to go for treatment. It's just not possible. But yet without getting that, they not only are not dealing with the substance abuse issue, but it's very hard to keep them out of their domestic violence situation as well. So, I'm thinking that there might be a way to collect that data, but it's not something that we traditionally have done because it's more of a secondary, goal for us in terms of looking at what we're doing, for our clients.
And if I can just sort of build on what Patty's saying as well, I've certainly, and I guess this is more tertiary prevention, I suppose. We're really lucky in Radford that if somebody's in for counseling, we can say, have you heard of Pier 401? You can go right down the street. We have Radford Transit here, which is free. And that is a huge boon that infrastructure is not as well developed in other areas. But I've had EA clients walk right out of the ER after an exam because they had opioid use disorders and they were asking, hey, can I get more opioids? And they didn't like how the staff was very respectful, right? But their feelings were still hurt. There's an immense amount of shame. And I think that for us in shelter, we're not a substance use disorder treatment facility, right? And again, we can't, like you said, take somebody to Pulaski at 6 in the morning, right? 7 in the morning from here, especially if it's more than one. If we're collecting real-time data, even like with COVID, that's going to be tricky because of that shame. Right, I don't want people to feel exposed or like their information is going to be used to criminalize them or take their kids away, right? Because that's, from the primary prevention standpoint, what I would be really concerned with is that somebody feeling rejected from the services that we have built, which are so excellent, whether intentionally or unintentionally, whether founded or unfounded, right? If they're feeling rejected, they're isolated and they can't get housing, they can't get reliable transportation, they can't get jobs, and their kids are then at risk within this system. And they're at risk of relapse, of overdose, and all those things. So I wouldn't want any real-time reporting system to seem like it could be used for, I guess, for lack of a better term, a sting? Yeah, for evil, right, exactly. That would be my fear.
Yeah. This came up in one other group. I think it's important to recognize awareness so that people know what's going on in their own backyard. And we can get overdose deaths and overdoses readily. We can get that data readily. And not as a scare tactic, but as this is in your own backyard. This is happening here. There's, addiction knows no discrimination. Anybody can be impacted by it, whether they're doing it directly or whether or not it's a loved one or a friend or a coworker. So I think part of our reach should really be about, we got this money because we recognize we have a problem here and we want to address it. And to use that as a positive approach that we're going to bring everybody along because it'll make us a healthier community, better workforce, and have better opportunities for us to succeed in whatever community you live. And I think that's got to be part of what this money is about, and just to be aware of it. And it can't be, oh, we're only worried about people who are in active use or in active recovery. It's a larger impact than that, and all community members have to have some buy-in to that idea that this is our problem and collectively we need to solve it.
Yep. And if we think upstream in terms of prevention and data collection, working with school systems around doing assessments and surveys of young people and their exposure to substances and substance use is incredibly important. We're making the case to re-implement the Youth Risk Behavior Survey in the local school systems, which addresses a lot of those issues with the questions that are contained in that survey, because we haven't, quite frankly, been able to do that for the last few years with COVID. So any data that we have around youth substance use or exposure to that is very outdated at this point. And we know how much the whole issue with opioids and fentanyl and all these other substances that are so prevalent now has changed since 2019 even. It's gotten a lot worse.
Well, and I did this funding from a prevention standpoint. We can look at underlying factors that, what we've talked, supportive factors versus risk factors for folks. And that's part of the reason we're looking at things like housing, transportation, looking at workforce opportunities. Like, are there some regulatory things that we could overcome so that people who are in recovery can get work that isn't, they're not being denied work opportunities because of their criminal histories and or because everybody in the shop that they're trying to work for is using. So it's really hard to find a place that is recovery focused. So I think the idea is that our entire community needs to recover from the impacts of opioids, and we can't just chase the opioid drugs themselves. We need to figure out what are the supportive factors that make us a less addicted community and more ready for recovery wherever we are in that process.
I think that's a great point, because opioids have not been the first exploitative scandal, and they won't be the last.
Right. Yep, exactly. Which takes us to the root cause of what causes folks to be in a position where they're challenged with substance use and addiction and trauma. Adverse childhood experiences all feed into that. And, clearly the homes where there's domestic violence, sexual violence, those are places where you're going to have a greater likelihood of seeing kids struggle with those kind of issues. So those of you who work in that realm certainly see a lot of that. Is there anything we could do more of to help those families and those young people that maybe we're not doing right now?
Are school counselors involved in the conversation in each area of the New River Health District?
So NRVCS has clinicians on site at all of our local public schools. So we're in there, but admittedly, it's a couple of people trying to serve an entire school, and the caseloads continue to build and climb. So it's tough to get to all the needs.
We do have funding in there to take a look at how can we create potentially some educational coaching. Instead of just, we tend to pile on to our schools, to our emergency responders, to our social workers, all of those folks. So how do we help the helpers who are doing that, and what are some of the resources that might be most important to be available to them? Is it training? Is it more bodies? How do we loop in our universities again? I mean, I think there was a period of time, again, leading up to COVID maybe, where schools started getting a little resistant to, like, we don't want to be your guinea pigs. And then we lost kind of a lot of good energy from university students and staff who wanted to be engaged in communities, really engaged. And then we aren't attracting teachers to educational programs like we used to, or nurses, or any of the folks that we know we need on the front line. So what are some of the ways that we feel like this funding has to take a look at some of those, workforce, not just preventing people who have a criminal history or a substance use disorder history from being employed, but just in general, we don't have people going into the helping professions in the way that we really know we need them, regardless of our addiction factors in the community.
Other thoughts around prevention education or awareness?
Yeah, yes.
Absolutely.
So you had mentioned that there are clinicians on site in the public schools in the area, and is that just every high school or is it at a younger? So I just wanted to hear more about the prevention. And is that just to bring awareness, or are they having conversations where students know that they can have these confidential? I know to a point, because I remember I was a school counselor, and you have to, if someone is, if someone reports something that does signify that they're in harm's way, of course, I know sometimes we'd have to report that, definitely. But I was just curious that they're doing something around just kind of reducing the stigma, but also having real conversations with the students. I just would love to hear more about that.
Staff are primarily working with a caseload of young people who struggle with access to those type of services and supports. As far as like transportation, being able to get to an appointment like after school would be difficult for them because of family structure, lack of transportation, those kind of things. So we're trying to get over those barriers and actually be on site at the school to meet them where they are to hopefully not disrupt their school day too much, but be there as a resource to provide services and support them. Did that answer your question?
Yeah, thank you. It's a pretty specific caseload, not necessarily general population care. It's very specific for the most at need and at risk, and yet isn't something that any student in that school could. Not that they wouldn't try to be helpful, but it isn't available to anybody necessarily across the school system.
And that caseload also overlaps too with kids that are truant.
Yes.
And you were talking about kind of addiction in families. It's not uncommon for an older child to be caught in a parental role, because the parent is just unable and they feel, and then school becomes kind of a second thought, or they're resentful, or it's just too chaotic to get themselves to school. And so I know in Radford, and I don't know about the other school systems, I think everybody's been overwhelmed coming out of COVID. And it's not unusual for us to have students at Radford City Schools that had 58 and 60 absences in a school year. I mean, you might as well throw away that grade. They didn't learn anything during that time. And I mean, that's not an uncommon number that we've seen.
Yeah, COVID eroded a lot of the structure that young people are wired to kind of build their lives around. And I don't think we've completely gotten back to that at this point. And as Vicki mentioned, there are a lot of families, households where older siblings or grandparents or other relatives are raising children because their biological parents are struggling with addiction, or they're incarcerated, or maybe they've passed away from an overdose. So a lot of really core family type stuff that I think is feeding into some of this. And if we're really thinking upstream and thinking about trying to prevent, more support, more resources for families that are in those situations that are struggling is, I think, a good investment. We want to be proactive and not reactive. We don't want to wait until somebody's struggling with addiction, that they have to be in an ER or they have to go to a residential treatment facility. We really want to try to get ahead of it. And that's how we eventually change the dynamic of our community.
Yeah, the education has to be all the way around, and we said this before when we've been sometimes this feels like the choir, but sometimes the choir needs to learn how to sing together a little bit better, and we all could learn some of the harmonies that are necessary for this kind of work. And so understanding our own bias and our own trauma and how that impacts the way we respond to others, that's something that community-wide we know we need.
Yeah. And Emile, to your earlier point, the shame, the stigma that surrounds us is still very real. We've got to be able to get our broad community to see this for the disease that it is, and not a matter of bad choices, bad people doing bad things, or some kind of moral failing, or some shortcoming of those people. This could and does affect us all in some way, directly or indirectly. So we really have to do a better job of selling our community on that. And not selling, but you know what I mean. We've got to convince them.
Yeah.
Convince them that is the root of the problem. It is a disease. It's not a matter of choice. It's not something that can be fixed overnight. It didn't happen overnight. So yeah. Were you going to say something else?
Yeah.
Grab your microphone.
Oh, right. Just thinking about what you were saying is I think it's absolutely true. Like many of us came into these fields that are helping professions in some respect because we've been impacted in one way or another. People we love have been impacted in one way or another. And I think in some ways that can be a struggle, and in other ways that can be a huge boon. You know, working in a domestic and sexual violence service agency, I see this every day, people grappling with their own trauma as we're serving other people. And this is one of the things that I think Peer 401 does really, really well, bringing people in to train others, saying, hey, you know, come here, here is a job. We want you. You have this experience. Your voice matters. Like, I think that's really valuable and destigmatizing, like, not to just gas you guys up, but I like that a lot. And I would like to see more of that, like, deliberately this open door of saying, you can't find a job? We made one for you. You know, like, we want you here. You know, I think that is something that we could look at.
Well, the stereotypes around addiction are still very real, aren't they? I mean, if you say someone's overdosed, you have this picture in your mind of what they must have looked like right before they died, you know. But that isn't the case, you know. So normalizing this, humanizing it, putting faces to it, putting names to it, seeing it the same way we see cancer and heart disease and diabetes, other health issues that are chronic that people live with that don't have to feel shamed. Addiction doesn't have to be any different. So acceptance, understanding, empathy, support, love, respect, dignity, all those words that sound great, but we've got to live them. We've got to practice what we preach. Anything else around prevention, education, awareness?
What swag do we need?
Ross and I know how to get some of that.
That's right.
Okay, well then we'll move on to harm reduction. Everybody knows what we're talking about when we're talking about harm reduction, right? What that means. Trying to support folks who are actively using that aren't in a position yet to seek professional help and enter recovery and get treatment. So we're trying to keep them safe, as healthy as possible, keep them alive, right?
Reduce risk.
Yes. So thoughts about harm reduction. We've done a lot, obviously, with naloxone, education, and distribution. But what else?
Brand new to this community. I just moved 10 days ago, so I'm asking a lot of questions. But do we have any clean needle exchanges in the area? Okay.
Officially.
Not legit.
I guess I asked a question that,
I mean, it never starts officially, so yeah.
yeah. I guess that's, a risky one to ask.
But
It's been approved by VDH to do those programs, but there has to be local support in order to make sure that it can be carried out. In far Southwest, there's a couple really, really successful programs, and they've been kind of shining light. Roanoke is starting to do it, and an area in Richmond is starting to do it. So it's gaining traction. Again, I think before you can jump in and do that, you have to have people understanding what the issue is, that we're trying to keep these people alive and basically healthy. And as part of what our health department does is we offer overall checks so that if you're going to come in for something like that, we also want to know what your Hep C status is. We want to know what your sexually transmitted disease status is. We want to know if you have open wounds. We want to be able to get you treatment. So it's kind of a more holistic approach than just safe needles, safe syringe exchanges. So it's more of the total body and just getting folks on board so that they understand they have value, and we want to make sure that we can keep them as healthy as possible. Everything does not get resolved with naloxone. There's got to be more to that, and I think that's where we are right now at that precipice.
want me to put you on the spot, Chris, but since you've done some of that work before, you want to speak to it?
So I've been doing the needle exchange programs for the last couple of years in Smith County, in Roanoke City, and harm reduction in Martinsville City, Henry County, Franklin County, Patrick County. But we can't do syringes there either, in those counties. We could in Roanoke City and Smith County. But what we have happening is people from Radford will go to Roanoke and get clean syringes and come back up here, which, there's tons of risk associated with that. Just driving on that interstate is a risk, you know what I mean? And then Virginia Harm Reduction Coalition, it's been around for a while. It's been there since 2019. And so they do clean syringes in Roanoke City. New River Valley, this is kind of what a lot of this is about, to kind of get people's feel for it in the community, I think. There's people are getting clean syringes in the New River Valley. It's just not at a capacity of community support. It's from people on boots on the ground, people who are going to Roanoke and getting syringes and bringing them back up here. All of this, for me stems from, I think, and I think Pam said it at one of the other lunch and learns, is that I learned the most from the people who are using drugs. You know what I mean? So I know when there's a bad batch in the area because they tell me. I know when there's a spike in overdoses because they tell me. I know when there's, I know when they need things because they tell me. And I think that's going to help a lot, is having people who are using drugs a part of this too. Because the whole stigma of people who are using drugs, it's still, and I've heard it in all the lunch and learns, is we're focusing on the drugs so much that we're forgetting there's a person there. You know what I mean? This isn't about the drugs. It's never been about the drugs. This is about people's lives who have been adversely affected since probably in the womb for some of them, and survived up to this point with basically whatever they had. And that includes drugs for the people we're talking about today. For other people, it's been obesity. For other people, it's been gambling. For other people, it's been porn addiction. Today, we're talking about the drugs, right? So, I think harm reduction is going to find its place in the New River Valley. I don't think it's going to be as radical as Roanoke is. Roanoke, we were out there in the freezing cold doing Hep C and HIV tests, giving out clean syringes, and we did glass pipes. We give out crack pipes, meth pipes, bubble pipes, safe snorting kits, boofing kits, smoking kits, tampons, pads, food, clothes, whatever. All right, so that's really what this is about. There's a whole population of people out there that are disconnected from their entire communities, including the services, because there's no feeling of safety there. It's like they're going to either TDO me, put me in jail, or treat me like crap, or all the above. You know what I mean? So those are the people that I talk to, and then we've got other people who, the high school kids and the elementary kids that are using drugs. That's a whole nother issue that starts in the home and in the community. We got to give kids something to do other than using drugs, to where it doesn't seem so appealing, right? So yeah, so that's a little. Yeah.
Oh, great, you're great.
Thank you for what you just said. But when you had talked before about part of the prevention piece too, and having some supportive factors, and I'm so sorry, I forgot your name, Chris. And Chris, what you just mentioned too about starting in the elementary school and something for them to do. So is some of the funding going to go to like additional, and I don't know around here if there's like ASP after school programs or other things that are already funded by the public school itself, but in addition to that, are there some supportive factors that we're just like piling on for some of these kids that we know might quote unquote be at risk?
Definitely, it's part of the prevention work. Again, a lot of it isn't officially defined yet, but there is some trying to look at children, but also teachers, and how do we help teachers identify where there's needs, and then also be aware of what resources there might be out there for those families. And then certainly we're working with child care providers and early childhood intervention programs to try to think about, is there, I don't know what the answer is. Is it curriculum? Is it more bodies? I mean, is it all of the above? So I think we have to keep having that conversation and say, we probably aren't going to solve this year, but what are some things what are some impacts, and then what are some data we can collect while we're trying something on with this group then that we feel like is making an impact. I think it's going to be a lot of piloting initially. We need to find, I've said that before, we need to find where there's some fertile ground, like a superintendent or a school system that really is ready to talk about this, to Pam's point, is fully aware that we've got issues and we need to do something different than what we've been doing because what we're doing isn't working. Even if what we're doing is working, it's not working at a big enough scale to have the impact that we need. So I know that's maybe a roundabout, but I don't want to say, we know this is the silver bullet. If we just do this, this will solve it all. But, I mean, I think it'll look really different in Radford than it might look in Giles and it might look in Montgomery.
Well, I mean, it's kind of like a really high-level look at the community. A lot of generational poverty, a lot of generational substance use, domestic violence, intimate partner violence that goes on within homes. And so, you can work with a kid in the school, but if they're going home to a really lousy environment, it's kind of a...
Can't know what you don't know.
Yeah. And for some kids, as far as like being able to have access to things like, rec sports or whatever, it can be a matter of financial strain for a family. So being able to fund, the cost of registration to be a part of a rec league team or something like that could go a long way to helping a young person overcome some of these challenges, to where they're maybe in a position where they feel more susceptible to experimenting with substance use or whatever. So it's really, we talk about this all the time. It's going to take all of us at all levels to really move the needle on this thing in a positive way. There are so many layers to it.
Yeah, I was just thinking about what you were just saying, the rec league and stuff like that. I think one of the things that I notice is that there's a really strong and sudden delineation between what is available to you as a teenager or a child and then what is available to you when you turn 19, right? You're done. It's over, right? A lot of programs that are available to support you when you're a child cease to exist. And then the kids that are like in their early 20s, like in different environments who are also vulnerable in their own way, cannot access those programs for some very legitimate reasons, right? But that's still a disruption in somebody who's trying to access support. And I've seen really good warm handoff between these different kinds of programs. But what you mentioned too, like it brings it back to transportation, right? Maybe we could afford, maybe my caseworker could support us in joining this soccer league, but I can't take you because I'm going to treatment at that time. And again, that leaves this child taking care of themselves, right? Not for any wrongdoing on the parents' part. The parents trying to do the best they can, but because of this disjointedness, like the support for parents and kids for that sort of interlocking between these two really stops after infancy and early childhood with the child care options that aren't everywhere, but are sporadically available. And like that's another point of vulnerability. I see people losing touch with supports that they've built.
That's a great point.
Something that Chris and Emil said, about kind of barriers to participating in sports, and Chris saying children need something to do. Well, if you have children that are truant, you've just piled on more idle time. You've given them more empty space to be able to kind of maybe make not the best choices for themselves. And so, I think having we know it has to be a multi-layered system, but, and what I imagine is, because we've talked about this in my office, I imagine that if we identify children in elementary school that are truant, they will still be truant in middle school or intermediate school and high school.
For them, for sure. No.
Right.
Yeah.
And they feel more left behind.
Yeah.
And, sometimes I think, too, the parents have had such a negative experience with public school. And so if problems start, the parent is also hesitant to meet with school administration because they hearken back to their days sitting in the principal's office or however that, yes.
And at that point, school can also be traumatizing for the children. If you're behind your peers, if you're getting bullied because maybe you don't dress the way that they dress, or maybe you have a mental health issue, or maybe maybe one of your parents overdosed and it became very public, local circle news. Those are also all reasons that the parent may look the other way or say, you know what, fine, you can stay home today, with like really good intentions, but furthering that isolation. And it doesn't have to be sports, it can be anything. I don't care if they're in an art class, they can be in a mosaic making class. It doesn't matter as long as they're connecting.
And you just mentioned the word isolation. We've talked about it in some of these other lunch and learns that we've done. And that really is a big factor for a lot of folks who struggle with this issue. Just not being connected to family, peer groups, social networks, being a part of the community, being accepted, feeling like they belong. There's a real lack of engagement.
Practicing some failure too.
Yeah.
It's really important too.
Yeah. So, any other thoughts about harm reduction? And you all know the issues around needle use, intravenous drug use, and the public health concerns around things like Hep C, HIV. Our rates in the NRV are extraordinarily high. And so beyond the issue around substance use itself, it's a public health concern because of the level of disease that's out there. Anything else about harm reduction?
Sorry to be me again. But on that point too, I think that one of the reasons that people often struggle is sort of policy. Really understandable. Again, like if somebody is using drugs at the shelter, like this affects other people at the shelter, right? And as much as I would like to be a safe place for anybody at any point in their journey, we can't always do that. And I'm assuming that's probably the case for most other agencies and schools, right? We want to provide support for this teenager who's disappearing to the bathroom every day and doing who knows what, right? We want to be a support for that parent who's, sneaking out behind the dumpsters, right? But we can't, and especially when it comes to places like homeless shelters, which we really, really need. Like, I can't tell you how many callers that we've had to say, I'm sorry, we just can't accommodate you because, they're not fleeing violence, they're not experiencing any violence, but they're at risk because they're living on the street, right? Like, but if we took every caller who contacted us, we would be over capacity, like every day, And there's not a lot of places that are stable, that are reliable, like the year round is what I mean. Like it's difficult to get somebody in a position where they're safe enough to save up some money and access more transitional housing options even here. And we're better than some other counties and places.
That's a great point.
And I think in this case, so I'm sure it's in other localities in the NRV, but the homeless population in Radford has really exploded. And part of it has been the ending of the eviction moratorium after COVID. I think people did not have realistic expectations. Just because you didn't have to pay your rent now didn't mean you didn't ever have to pay your rent. So I think, anyway, and so the most alarming for me, it's also created this pocket of homeless people that are elderly. And they're living by the river, and because they were on fixed incomes anyway, and then all of a sudden they have this gigantic rent bill. And, we haven't had, the funds to pay it. Periodically, during COVID, we got some funds to help with utilities and other things, but it always had the caveat that you had to have a really direct line, like you had to prove that because of COVID, your hours got reduced, and so not everybody that came got funding for that, for assistance. And then, we all talked about it at meetings. We knew there'd be a cliff by which all these waivers, all these things would lift at approximately the same time. And that's kind of exactly what happened. And they just fell off a cliff.
Perfect storm.
Yeah.
Right.
And what's the HUD wait time?
Yeah.
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 Yeah. Yeah. Safe, affordable housing is a huge concern for not just folks who struggle with addiction, but our communities in general. I feel like folks are kind of marginal in those areas of life are being squeezed.
Yeah, under DSS umbrella, I also have the housing voucher program, and we opened the waiting list recently, and we had 800 people on our waiting list. So, and even at 250, which was normally our old number, it would take years to work your way down that list because we're at capacity with vouchers, and so someone would have to not need it or get terminated for the program in order to open someone else back up. So it's a slow drip, drip, drip.
Well, that is one thing with the supportive housing folks that we were talking to, that in Virginia, we don't allow project-based vouchers, and that may be an option, like that there could be something that potentially New River Community Action is looking at building a facility that then would be for the very low income, but then that whole project would be voucher specific. And I don't claim to understand the politics of that, but in Virginia, we don't allow that you have to you get a voucher, but then you have to go negotiate with random landlord to try to get them to accept the voucher. And so if we could do some project-based, that may help us some, but then you have to understand the NIMBY concerns that go along with that. But I want to say to people, I'm like, you think these landlords aren't, this would be a project that would be supported with supportive services wrapped around it, whereas the landlord I don't think they're better in most cases.
And I mean, I hope it'll improve, but right now, Radford University's census is really down. You can't tell me there aren't some vacant apartment buildings already existing because a rehab might be less expensive than brick and mortar from the ground up, because right now, we're close to half the student population that there was a few years ago. That certainly has to have created vacant, and Radford University also did so much better in building dorms as of late, and newer apartments, which I'm sure if you have the choice of apartments, you want to live in the shiniest, newest one there is. But I can't imagine that there's not some housing stock in the city of Radford that might be able to be creatively used.
It's an interesting thought.
Like what they did with the old elementary school just off on the way to Blacksburg that way. I love that there's businesses there, and there's some housing set aside for HUD, and there's some just like rent it normal ways housing. I'm like, that's great, because if I'm on a HUD voucher, I probably don't have super reliable transportation. I probably don't have a lot of access to other places. These are places where I can go and, again, find that connection and, like, maybe even gain employment and interact with other people without feeling like I'm in a project. Like, Radford has vacant buildings. Everywhere has vacant buildings. We can do it. But, again, the volume of people, the volume of need is daunting.
All right, so we'll merge into discussion about treatment itself, getting professional help for people that struggle with substance use disorders.
And co-occurring stuff.
And co-occurring, often with mental health issues of some kind. Thoughts about that? Concerns, ideas, opportunities?
There is funding in here for medically assisted treatment, as well as lots of support through New River Valley Community Services, through their mental health services and outreach and prevention, all of those pieces. It feels like sometimes to me, the integration between treatment, prevention, recovery is small.
It is.
That there is a need to have those services all wrapped around, which is part of the reason this ecosystem work has been set up, so that people can understand that you can be doing prevention of something while you're also doing treatment for something else and be in recovery around other pieces. So the intention would be to have it be cyclical and accessible, regardless of where folks are. But Community Health Center does medically assisted treatment. They do some fantastic bridging out of the ED in Roanoke that we're hopeful we can build here in the New River Valley, so that people who end up in the emergency department because of substance use disorder can get initial treatment there, with the idea that then they get a warm handoff to a clinician who will continue that treatment for them outside of the ED. Yeah.
Holly, I can't remember if you were on that field trip as well to West Virginia. And there was a small treatment facility, and it allowed pregnant women, and they went to the hospital and they gave birth, and they could come back to the facility with their newborn. And so it took DSS removal right off the table because they were in a structured setting. Now, in that case, the state of West Virginia, they kind of lucked into that. If I'm remembering the story correctly, there was a building that was slated for another purpose, but it was still going to be some kind of residential treatment. And whatever that initiative was, it fell through. And so there was this perfectly good building set up like residential treatment, and they decided to use it for this reason. But it had total state support. But it served, it's not very far across the West Virginia line, but it served
area,
all
yeah.
of West Virginia. And we got a chance to tour the facility and then meet afterwards with some of the people in charge. And we were really impressed, and I know that sticks in my mind, will there ever be an opportunity for us to kind of put that into action?
Kind of campus treatment. I mean, there isn't anything in this current year for, natal abstinence syndrome children, because, again, housing that is complex, but I don't think that that's out of the realm of something that we need to take a look at longer term. Pam, you were going to say something?
Just that we also need to convince our medical colleagues and professionals that they ought to normalize treatment for regular patients, and that you shouldn't have to set up a clinic so that, at 4 o'clock every Friday afternoon, all those folks with this disorder get to come in. That does not build trust with anybody going through recovery, right? And so I think that's the other piece of it, is that we need to really educate all of our clinicians and let them know that medically assisted treatment should be part of your everyday practice, because by golly, you're going to see it in almost every age group that you deal with. If it's not your pediatric patients, it might be their parents. And can you not make that referral off to the right people? So I think that's part of the awareness and education, and that's what we're trying to do in PATH, is to get folks on board that, hey, you too can be doing what Dr. Roberts does through the community health centers, and you can treat everybody, and they don't have to have a special time and be stigmatized as they walk in the door on, like I said, every Friday at 4 o'clock or something, when it's not going to be other people around. Same thing with our safe syringes and safe needle exchanges. It can happen as a regular part of a clinic. It doesn't need to be clandestine, and we don't need to further stigmatize people that are actively trying to do well for themselves. And MAT has got to be part of this whole picture. And inpatient clinic is a whole lot different than outpatient services. But boy, think of it, if we could do more outpatient work, we wouldn't end up with so many having to go to inpatient.
Well, and I know that one of the clinicians was at the Giles event with the Community Health Center, and they do, and I think Tri-Area wasn't there, they were at Floyd, but they do a 30-day injection that apparently is very effective, and also kind of reduces that pressure and one more appointment that somebody who's also dealing with substance use disorder and trying to get to work and trying to keep their house and all of those things, if we can do. And apparently it's not more expensive. It does require somebody who's has a medical degree to administer it, because it is an injection. But I think there are things that we all could become more educated about to understand, so that then when you're having conversations with your general practitioner or something, I mean, even just for me, I had my appointment with my general practitioner. I said, do you think I should get the RSV vaccine? I'm in and out of the schools all the time. I'll turn 60 this year. And she's like, I don't know, it's kind of new. And I'm like, well, I heard from the doctor, and I said, let's print this out. And she's a fantastic doctor. I'm not going to, but I think they're kind of like educators and social workers. We've piled a lot onto their plate, and we have to find ways that at least we can say, this needs to be priority. Here's some priority elements. This is a way to help you understand this better and more effectively, so that we can all get clearer about how to help people mitigate risk. What are ways we can help people mitigate risk? And yes, I should get the RSV vaccine because I have a low-level asthma, and I'm exposed all the time. So, just so you know. Yes, and but get your RSV at least 30 days before you do that. That's right.
I think the important thing to keep in mind when it comes to treatment is that the method of treatment that works for one person may not work for the next. Yeah. And treatment and how a person gets into recovery and is successful in that is as unique as the individual themselves. And so what works for one person might be medication-assisted treatment. The other person can maybe just get help through outpatient therapy. I mean, we have to be open-minded about it. And as someone said so beautifully a few weeks ago in a conversation I was having about this issue, we don't treat all cancers the same, right?
Yeah.
So.
We don't shame people when they decide they want to try something different too.
Right. Or discontinue treatment.
Yes.
They're not shamed for that. So. And addiction is a disease that's very prone to return to use and relapse. We know that too, right? So we have to understand that as part of the picture. We can't just roll our eyes and shake our heads and say, man, knew that was going to happen, and add to that shame and stigma. When a person is really trying to get better and to be healthier.
Even the CDC's definition of recovery is a path towards wellness. Mm-hmm. And so I think, again, we're all on the recovery path, hopefully, towards wellness. Yeah. And it's not going to be straight, sometimes really steep.
Well, the medication-assisted treatment issue is maybe not quite the sticking point that needle exchange is, but there's still a lot of pushback about that in our community from folks in power, elected officials, people that make decisions about how money is utilized and allocated. So there needs to be a broad level of education for our communities about the benefits of a practice like medication-assisted treatment.
And different recovery programs have different feelings about it, too. So I think, too, that's something we need to be clear about, is that there, to Mike's point, should be an array of options, and people should try things on. If this feels like this might, a faith-based program is really going to be useful to you, there's several of those. And if you don't want that, here's some other options. Or if that didn't work the first time, not going to tell you, because you chose that one, this is the one you're going to stay in until you beat it out of you. It can't be done.
Any other thoughts about treatment? Okay. Last topic we'll talk about is recovery itself. So we've talked a little bit about certified peer recovery specialists, folks with lived experience who are now often part of direct service treatment for folks who are struggling with addiction. What else in terms of recovery do we need to be doing more of or expand upon? Or what's not good that's already in place? Any thoughts?
Just so, one of the things we're working on is, I'm sorry, both of you were, go ahead. No, just working with businesses about how do we create a recovery-safe workplace for folks, because in the same way that we want to make it feel safe that people who are around harm reduction, when people are in recovery, there's needs for safety there too. And how do we help people stay on their recovery journey in the workplace, in the school? I mean, Virginia Tech has recovery dorms, Radford has a recovery community. What are the ways that we as a community can create recovery spaces for people to feel like it's safe for me to be doing this really hard work?
Any thoughts?
Yeah.
I was going to say, you basically spoke to the point that I had in mind, and that is that there really has to be some level of continuity of care in all areas of the community. Business is one, schools another, but also civic organizations, places that are a little less obvious, that I think if we can get creative in thinking about how to make inroads, it could be a neighborhood association, for example. You know, a home becomes available for rent in a neighborhood that you wouldn't think about placing because of the bias, someone in recovery, but that could be a perfect opportunity. So I think just staying attuned and responsive to where those opportunities are.
I've heard some good things about the Oxford houses that are kind of coming into the area. Yeah, on that. I think a couple of them have been here for a little while now. But they seem to be becoming more numerous, which, again, I've heard good things. Space is always highly competitive. It does make me think, like, one of the really limiting things about living in poverty or just being broke is that you don't feel like you can really plan for the future at all, which I think contributes just to a lot of the behaviors that we're talking about and a lot of the experiences that we're talking about, this very term limited, like, well, you know, what's going to happen next week? I have no idea, right? And I think that, again, this sort of brings me to, like, the criminalization and court costs and things like this. And I would like to see people feeling like this isn't the end of their life, you know, that you have a warrant out, right? You know, that immediately is putting somebody absolutely terrified, absolutely on the run. Even if it's something that, like, we as advocates, right, have seen before, have dealt with before, can help someone navigate. It's a terrifying prospect. And that's not something that I want to see somebody who's experiencing addiction right now feeling that as well. So I think that that's a place where our local PDs could really come in and be really strong allies, say, hey, if you're experiencing this, this is something you can do. This is what you can expect. You do not have to be afraid, right? And then holding the officers and detectives to that plan.
Other thoughts?
One of the places where I also serve is the Workforce Development Board, and I know that they're really trying to expand the populations that they served, not only justice involved, but also recovery community, and part of that is just the shortage in the workforce and labor force, and realize that they have to look broader, and maybe employers originally discounted this kind of population of people that could really be strong and loyal employees for them. And so, you know, I realize that, you know, there are a lot of agencies represented today, but there are some agencies that are not. And I think workforce development is not something we can discount. Because if you look at recovery, and part of what Emil said about chaotic life, you don't know what's going to happen because your money is so unstable. If you're able to get some kind of employment, that helps you know what next week is going to look like.
Yeah. Takes you out of survival mode. Yeah. Well, you know, advocacy, pushing our elected officials toward policies that are more accepting and forgiving of folks who have substance-related criminal charges is one thing that we can all do and all have a voice to be a champion for the folks who are in recovery that are trying to get back on their feet, to speak on their behalf and to really be their voice. Chris?
Gosh, I'm not going to get emotional, I promise, but I've been in recovery. Next week will be 19 years, right? And that does not mean abstinent. I just want to throw that out there. I'm not that guy anymore. But what I want to say is that not only for people who are using drugs and not only people who are early in recovery, there's people that do this work that's been doing it a long time. And it's very, very hard work at times when you're a peer. I've been a peer since 2009, certified since 2016. And what I can say is I had a major, major, major mental health break in 2019. And all these relationships that I'd built since 2009, gone. I had no one. So for the next 2.5 years, I sat by myself in my trailer, suicidal, because I had no one, because everybody had put me on a pedestal, or so it seemed to me, right? Because the 401 Peer Center, I started that, you know what I mean? That was my project. And I wanted to get a youth 401, you know what I mean? For Radford, I wanted one for the kids to go to. I did all these things, but when my mental health deteriorated after 16 years, there was no one. And that hurt bad, and I'm lucky to be here because of that, you know, after all that. Well, I say all that in saying this. I would love, and I've talked to some people in Richmond and D.C., I would love to get statistics of people in long-term recovery who have committed suicide because the drugs don't work anymore, and we know that, right? We're supposed to be these upstanding citizens now because we've stopped using drugs, but only to find out the drugs were never the issue to begin with. It was childhood trauma, right? And so people just give up at that point. And so my thing with it all is that even with the peer stuff, you know, we put peers on a pedestal, which is great, but we also have to make sure we're taking care of those peers. I've seen a lot of peers since 2016 get certified and go back to using drugs because they couldn't keep up with the documentation of this job entails. And so I've been working with New River Community College to try to get some courses and a certificate so peers can have some training in school courses, so they're just not thrown in a course thinking or into a job thinking I'm just here to help people. So the bottom line of all this is we got to take care of each other as much as we got to take care of the people we're trying to serve, because I almost lost my life because of this, right? I've dedicated my whole life to this stuff since 2004. And when I needed people, there was nobody there. And this is not a pity thing because I'm resilient as hell and I'm back here before you again. But it's hard, man, and we need each other, like for real. Whether we're still actively using drugs, whether we've never used a drug, or whether we've been in recovery for years, like, this is a we thing, you know what I mean? It doesn't matter about all that other stuff as much as it is, if I see Mike and he looks like he's having a rough day, what's up, Mike? What's going on? You know what I mean? And Mike, he's one of the, like, most innocent people I know. You know what I mean? So, anyway, I'll stop at that. I just want to emphasize that we've got to take care of our people, ourselves first and foremost, right? But these peers and these other folks working in this field that we have, you know, high opinions of, make sure they're really doing okay. And if they do have a mental something happened, like, and I didn't have a relapse. I didn't use drugs again. You know what I mean? I had something that it didn't have nothing to do with drugs, but I lost my job and my marriage all within a year, right? And nobody was there. That hurt. Please don't let that happen to nobody else. All right, that's it. Thanks.
Thank you, Chris.
Yeah, I think absolutely. Yeah, seconding, thirding, etc. That secondary traumatic stress is a huge contributor to the deterioration we were talking about right at the beginning. You know, we can't just put people on pedestals and then just let them shatter when they fall off. Like, we set folks up for failure, you know, and I think, again, it's because of this dichotomous relationship. You're the caregiver or you're the patient, right? You're the advocate or you're the victim, right? When that is not the complex reality of what's going on. And we don't necessarily live in a world that has built infrastructure for that. So it's the least we can do in our agencies to, like, do something, right? And exercise basic human compassion, like checking in with folks, you know, and recognize that if somebody is going through a crisis, is having a mental health crisis, has cancer, right, is relapsing, it doesn't matter what it is, has a death in the family, like, our first concern should not be, oh, how are we going to keep up with their work? Like, that's garbage, just frankly. You know what I mean? And that contributes to that burnout, because then not only are they depressed, not only are they experiencing whatever they're experiencing, now they feel like a burden too. Like, and that is why, part of the reason this room is so empty right now, because I'm sure all of you all are thinking in your agencies, how many good folks did you lose because they quit, because they retired, right? Because there was a crisis that they couldn't overcome, right? Because something else happened to them, because they committed suicide because of something else. We all know, I'm sure, at least one person. Like, and maybe that's, you know, maybe there's something we can learn from that, move on from that as a community of caring people. That we just can't do that. We can't be abandoning one another. That's not how humans naturally are. That's not, we can't buy into that system. But yeah. Anyway, yes, absolutely.
Basic human compassion. I like
Nothing
it.
basic about it.
Yeah.
Pam, sorry, yeah. No, go ahead.
I was just going to say that I hear about the secondary trauma, and I do. I would also add that maybe some seats in here are empty because some of us don't feel like we can even take 2 hours, right, from our jobs to come to something like this, because I have spent a few moments like, oh gosh, okay, so after this, right, it's going to be 1 o'clock, and then I need to do this, this, and this, right? But I did also want to offer that part of my, so we got a grant, NRV Cares got a grant for creating healing-centered organizations, and so that's how I've stepped into this role as the Resiliency Network Coordinator for the NRV. But one thing that that I am putting some thought and research into is how can we kind of target that secondary trauma, and so how can we offer some spaces for all of us that need that kind of training, that need that kind of attention, so that we can support each other. So I don't have anything ready to roll out, but that is something that I have given some thought to, because what we are seeing is that that is a need, even within our small organization that relies on a lot of volunteers, but we need to help each other out a little bit more with that kind of secondary trauma.
Absolutely. Pam?
So I will just add to the mix that one group of folks that can readily do some type of that landing space that's safe is the faith-based groups. And I don't see anybody here from that. At 1 o'clock today, there's supposed to be a really good, I think it's at 1 o'clock today. It might be at 2:30. I have 2 of them I have to go to as well. A meeting about how you help the recovery program through your faith-based organization. So it doesn't have to be based on religion, but can you as an organization that does a lot of outreach, that does a lot of caring, offer a safe space for people to be able to come and gather together? And I don't think there's any safer space than a religious setting or a housing that people can come and go and feel comfortable there. So I will make the pitch that we need to definitely have more faith-based folks involved. So when you go back to leadership on the 30th, I think there needs to be a concerted effort to bring in some of those point people from our faith-based communities that need to be involved with this, because they're the ones, honestly, that a lot of folks go to before they'll go to an agency when they need that $100 for rent, they need that gas money, they need to put food on their table, and they respond. But they're tapped out and stretched too. So if some of this money can go towards them, for them to further develop their programs in their own community where people know them and trust them, I think that's one strategy we have to use. Another strategy is, I think you said it, Holly, we don't need to reinvent the wheel. So I would encourage your leadership team to find similar communities that have had successful programs and go visit them, go learn. What were your greatest successes? How long did it take? I want people to also be aware that this is, 5 years that we have this money available to us. We're not going to be fixing this in 1 year. I mean, we're lucky if by year 3 we've made significant strides. And I think that we have become a society of instant gratification. And if we're not seeing huge changes, especially if we're depending on data, and they say, well, we've done this for 3 years, it hasn't budged anything, it's only gotten worse, which I predict it's going to get worse because people should feel more comfortable coming out and talking about it and having it destigmatized. And so we may see numbers go up. And as soon as folks around us know there are resources, instead of going to Roanoke, we may have people from other areas coming here for assistance. So we may see our numbers go up. But we need to be able to be realistic about that timeline. And I'm, again, encourage the leadership to not just say, well, Radford wants to do it this way, Montgomery wants to do it that way. It's like, no, okay, so what's a similar population somewhere else that's had success, and what does that look like? And I think that'll save us some time in the long run, but also help us be more thoughtful moving forward with programs that are going to be locality specific.
Thank you, Pam. Thanks. Any other thoughts about recovery? Or for that matter, anything else that we've talked about today?
Law enforcement, they need to be on the table.
Yep.
They do.
They've attended a couple. Not Radford's, but they've attended a couple.
Yeah, we've had some law enforcement representation.
And there is a chunk in there for temporary detaining order support that I know there, and actually Radford was a community that was doing some more embedded, folks from New River Valley Community Services some ride-alongs when they had mental health calls to try to de-escalate and provide some support. I did meet with a police department last week and was talking with them about it, that they thought maybe about anywhere between an eighth and a third of their calls might be mental health or substance use related calls, but it takes up about 60% of their time because those calls require a lot more intensive support, and they're not really designed for them. They really know that that is not where their forte is. They're looking for the physical perimeter and how do I physically protect this space without necessarily, kind of to your point, thinking about with compassion. And not even that they're not compassionate. They just, their job is trained to see a threat and eliminate the threat.
Right. Or unfortunately, sometimes even to escalate a given conflict, and it's not.
Yeah. Well, and sometimes you don't know how to de-escalate. I mean, de-escalating for folks in those situations is not a rational conversation, potentially. So I do think we are talking about trainings and things like that, Pam, but also how do we alleviate some of that from that group that maybe shouldn't or isn't the best group to be engaging in those situations. I mean, wellness checks is something we want to be able to call our police officers and say, I'm concerned about this person who's not responding to, this, and this. But then the intention would be that we're providing support versus, interrogation or arrest. And it's just, it's a weird balance, and it will look different in a lot of places. But the intention is to provide resources for communities to address what those specific needs are.
I've had some limited success with clients having mental health crisis being on the line as the wellness check is called. I'm thinking in particular about clients that are having really severe paranoia for whatever reason, because there are many, right? But my fear, especially as we're talking about, law enforcement or, the churches, is that we're missing people who have been traumatized by those very institutions. There are a lot of people who, even if they desperately need EMS, won't call them because they're worried that the cops will show up, right? And that's not to say we don't have wonderful, compassionate, fabulous officers who are invaluable allies to all of us at some point or another, but it's also true that I've heard very unfortunate reports from other folks, especially people who are caught underage, drinking, using drugs, these things. And again, that can be the worst night of your life, right? Let alone if you've experienced a crime, So I think that we have to be very careful and very gentle about saying, these are the community institutions, because the most isolated people have already been isolated from that.
And I don't know if anybody's here from Virginia Tech, but when I did meet, we talked about they have a number that's anybody who's faculty, staff, or student can call on the campus, and it's some kind of support that will connect you with somebody, telemedicine, and it can be physical, mental health, or substance use disorder, any kind of concern. And the intention is but they also then are connected to the local services so that if that person seems, after talking with them, they, are concerned about harm, self-harm or harming somebody else, they can connect to, on-campus services in that case, or to New River Valley Community Services or police or whatever that might be. But they would keep that person on the line while they're talking to him, saying, I've made some contacts so that somebody physically is going to come here, and this is the intention of that call. I think it's something to consider for our region, even though telemedicine doesn't meet every need. It can be a little more immediate for folks who need that, and perhaps that's a service that if we had it not just available to those on campuses, even though I don't want to take it away from them, but community-wide, how do we provide the opportunity for somebody saying, I'm not sure if I'm okay, and how can I potentially call somebody who could provide some service to me?
Our agency has a
Hotline.
branch of service that's called Mobile Crisis, where we basically go out into the field, into the community, and address the needs of people who are experiencing a mental health crisis. It makes me think, and I'm sure this has been considered at some level somewhere, that we have some kind of structured mobile response for people that are struggling with substance use. Maybe the people that wouldn't go to a faith-based facility or law enforcement to get help.
Well, with the mobile unit, it's possible that some of that stuff could
Yeah.
be folded in too. We've talked
Yeah.
about that, like, people should have, I think Chris has said it before, but like, the ED isn't a very welcoming place for any of us, probably, but it certainly isn't for people in a substance use crisis.
I guess I'm thinking if we had just like a mobile unit, like a car or a van that would go out, that covers Giles, that covers Floyd,
Yeah.
that covers Radford, to kind of divide up the territory so the response time is better.
Yeah.
I don't know. I'm thinking out loud as we're talking.
Well, I think we have to, and we are in a rural place where we know transportation and access to services, but what we also want to be careful of, even with the mobile unit, is it doesn't become known as the drug bus or it used to be the sex bus, because we did a lot of STI testing. But so I think the idea would be this is the mobile medical unit bus, and it has services on it, a variety of services that everybody in this community can access. And there's not a reason to believe that you can't, if we can't help you on the day that the bus is there, we will be able to refer you to somebody who can.
Being at farmers markets, being in grocery store lots, those sorts of things. Yeah, maybe we do substance use treatment referrals, and maybe we also have ice cream.
That's right. Or we give out, all the extra zucchini from your garden. Some of them are getting really big now.
Does anyone have any other thoughts or ideas or concerns before we wrap up?
My email is on the bottom of the form. I know you've got Mike's email because his the invitation. So please do reach out if there are things that come up that you're like, oh, don't forget to do this for Radford or the region.
And did everybody sign the sign-in sheet?
Yeah, because that's a way too. We'll let you know as things change. There will be technical groups. You guys didn't yet. Where is it? Sign-in sheet. Oh, right here.
So for those of you who aren't aware, we also have the local community prevention coalitions, including the Radford Youth Adult Partnership here in Radford. We typically meet the first Thursday of the month over Zoom at 4 p.m. for about an hour. It's a great way to stay involved, stay up on things around prevention and education. So if you're not already part of that group, let me know. I'll get you signed up. What else? Anything else to talk about before we say goodbye? Okay. It's going to take all of us, right?
Yep.
This is not an easy fix, and it's going to take some time. As Pam said, this isn't going to be covered in the first year of this grant. This is in for the long haul.
But hold our feet to the fire.
Yeah.
We got to, if we're not doing it right, we need to know, because how else, if it's not working, doesn't mean that it can immediately work sometimes, so that may be the answer, but certainly the intention is not to beat our head on the wall of something that can't be addressed.
And if you'd like to take extra copies of the flyers or the little notebooks with you to your offices, feel free to do that.
And I think there's more pizza.
All right.
Thanks.
Thanks, everybody.